We begin our investigation where life itself begins and ends, inside the vast, silent network of the blood vessels. This is not merely a system of plumbing. This is the stage for the greatest thriller ever told, a story of life and death played out in a metropolis of trillions of cells. More than any other category of human disease, it is here, within these crimson rivers, that the battles for survival are most often won and lost. The pathology of the vasculature is responsible for more morbidity and mortality than any other adversary we will ever face. Though the high-pressure, high-stakes world of the arteries will command much of our attention, we must not discount the quiet, low-pressure intrigues of the venous system. The threats are universal, and they are governed by two fundamental mechanisms of failure. The first is a slow strangulation, a narrowing, or stenosis, of the vessel's channel, the lumen. This can be a progressive siege, like the relentless buildup of atherosclerosis, or a sudden, catastrophic blockade, like a thrombosis. The second mechanism is a failure of the wall itself, a weakening that leads to a terrifying dilation or an explosive rupture. To understand how these failures occur, to begin our investigation into the diseases that exploit them, we must first understand the landscape. We must tour the architecture of this incredible system, for it is a vessel's very structure that dictates both its destiny and its deepest vulnerabilities. The metropolis of life, a tour of the interior highways. Imagine the human body as a sprawling, intricate city. The blood vessels are its highways, its boulevards, its quiet residential streets. And like any great city's infrastructure, its design is a marvel of specialization. Arterial walls are thick and powerful, engineered to withstand the punishing, pulsatile flow and high pressures generated by the heart's rhythmic contractions. As these arteries branch and become smaller, their walls gradually thin, but the ratio of wall thickness to the diameter of the lumen actually increases. This design gives these smaller, muscular vessels precise control over blood flow and pressure, allowing them to act as the city's traffic controllers. This specialization is the key to our investigation. It explains why different diseases target different parts of the vascular tree with such unnerving precision. Atherosclerosis, the great hardening, wages its war primarily in the large elastic and muscular arteries. Hypertension, the silent siege of high pressure, focuses its assault on the small muscular arteries and the even smaller arterioles. And the many forms of vasculitis, the body's immunological civil war, often choose to attack only vessels of a specific size. The architecture of a vessel is its fate. The fundamental building blocks of these walls are the endothelial cells and the smooth muscle cells, held together by a scaffold of extracellular matrix, a complex weave of elastin, collagen, and glycosaminoglycans. These components are organized into three distinct, concentric layers, most clearly defined in the arteries. First, there is the intima. This is the inner sanctum, a single, delicate layer of endothelial cells resting on a thin basement membrane. It is the city's inner surface, the very interface between the river of life and the tissues it serves. A thin barrier, the internal elastic lamina, demarcates it from the next layer. That layer is the media, the mighty wall of the vessel. In the great elastic arteries like the aorta, the media is a masterpiece of engineering, arranged in layers of elastic fibers and smooth muscle cells, like the rings of a great tree. This high elastin content allows these massive vessels to expand during the heart's powerful systolic contraction and then recoil during its diastolic relaxation, a secondary pump that propels blood forward into the tissues. With age, this elasticity fades, and the great arteries become less compliant, more rigid, leading to the progressive dilation and tortuosity we see in the elderly. In the muscular arteries, the media is composed primarily of smooth muscle cells arranged in a circular fashion. Their contraction or vasoconstriction and relaxation or vasodilation are the primary means by which the body directs blood flow. Finally, we have the adventitia, the outer scaffolding of the vessel. It is a layer of loose connective tissue containing nerve fibers and, crucially, the vasa vasorum, literally, the vessels of the vessels. In the largest arteries, the wall is too thick to be nourished by simple diffusion from the lumen. The vasa vasorum is a dedicated network of small arterioles that penetrates the outer layers of the media, providing the oxygen and nutrients needed to keep the vessel wall itself alive. The compromise of this vital supply line is a vulnerability we will see exploited with deadly consequences. This architectural plan is adapted throughout the system. The great elastic arteries, like the aorta and its major branches, are the conduits built to absorb shock. The muscular arteries, like the coronary and renal arteries, are the regional distributors. And then we come to the arterioles. These are the gatekeepers of the metropolis, the principal points of physiologic resistance to blood flow. Here, the laws of physics are absolute and unforgiving. The resistance to flow is inversely proportional to the fourth power of the diameter. This means that having the diameter of an arteriole does not double the resistance, it increases it 16-fold. A tiny change in these microscopic vessels can trigger a systemic crisis of pressure. Beyond the gatekeepers lie the capillaries, the bustling marketplaces where the real work of the city is done. They are so narrow that red blood cells, the city's delivery trucks, must pass in single file. Their walls are composed of little more than a single endothelial cell, making them perfectly suited for the exchange of gases, nutrients, and waste. From here, blood flows into the low-pressure return channels, the venules, and then the veins. Veins have larger diameters and thinner, less organized walls than their arterial counterparts. This design allows them to serve as a vast reservoir, holding, on average, 2/3 of the body's total blood volume. In the extremities, they are fitted with one-way valves to prevent the backflow of blood due to gravity. Running parallel to this entire system is a second, more mysterious network, the lymphatics. These are thin-walled, endothelium-lined channels that drain fluid, proteins, and cells from the spaces between tissues, eventually returning this lymph to the bloodstream. They are a critical part of the body's immune surveillance system, transporting inflammatory cells and foreign antigens to lymph nodes for inspection. But this vital function is a double-edged sword. These same channels can become routes of dissemination for microbes and tumor cells, allowing disease to spread to distant sites. This, then, is our crime scene, a network of staggering complexity and elegance. But within its very design, within the specializations that make it so efficient, lie the seeds of its own destruction. The aorta's reliance on elastin makes it vulnerable to aneurysms when that elastin degrades. The arterioles' muscular control over resistance makes them the primary battleground for hypertension. The low-flow state of the veins makes them susceptible to deadly clots. As we proceed with our investigation, we will see how every form of vascular pathology is, in essence, a story of a brilliant design being turned against itself. Our tour of the vascular metropolis is complete. In our next transmission, we will open our first case files, investigating blueprints of betrayal, the rare but devastating cases where the architecture is flawed from the very start. Blueprints of betrayal, when the architecture is flawed from the start. We now continue our investigation into Part 2, Blueprints of Betrayal. While many of the threats to the vascular system are acquired over a lifetime of insults, some are woven into the very fabric of the body from its inception. These are not diseases of wear and tear, but congenital design flaws, latent vulnerabilities that can lie dormant for years before revealing themselves in a moment of catastrophic failure. These cases are rare, but they are critically important, for they teach us that the threat can come not only from without, but from within the blueprint itself. Our first case file concerns developmental aneurysms, often called berry aneurysms. These are small, saccular outpouchings that occur at the branch points of cerebral arteries, hidden structural weaknesses in the vascular supply to the body's command center. They are ticking time bombs, often silent for decades, whose rupture can cause a fatal intracerebral hemorrhage. They represent a fundamental flaw in the wall's construction, a weak point waiting for the right trigger. Next, we examine arteriovenous fistulas. These are abnormal, direct connections between arteries and veins that completely bypass the intervening capillary network. Imagine a high-pressure water main being connected directly to a low-pressure drainage pipe. The result is a dangerous short circuit. While sometimes created surgically to provide vascular access for hemodialysis, when they occur as developmental defects, they can be disastrous. By shunting large volumes of blood from the high-pressure arterial side to the low-pressure venous side, they force the heart to pump an ever-increasing volume of blood to maintain adequate circulation to the rest of the body. This relentless demand can lead to high-output cardiac failure, a condition where the heart literally works itself to death, trying to compensate for a fundamental flaw in the system's wiring. Like berry aneurysms, these fistulas can also rupture, causing massive hemorrhage. Our third case file is one of the most bizarre architectural anomalies we will encounter: fibromuscular dysplasia. This is a focal, irregular thickening that occurs in medium and large muscular arteries, most notably the renal and carotid arteries. The cause is unknown. The vessel wall becomes a patchwork of thickened segments due to a combination of medial and intimal hyperplasia and fibrosis and dangerously thin, attenuated segments. On an angiogram, this gives the vessel a characteristic string of beads appearance. This is not merely a radiological curiosity. The thickened segments cause luminal stenosis. When this occurs in the renal arteries, it becomes a direct cause of renovascular hypertension, a case where a flawed pipe in the kidney triggers a systemic pressure crisis that affects the entire body. Meanwhile, the adjacent thin segments are prone to forming aneurysms that can rupture. Fibromuscular dysplasia is a perfect example of a congenital flaw creating a cascade of devastating, acquired pathologies. Finally, there are cases of anomalous coronary artery origin, where a developmental error results in both coronary arteries, the heart's own vital blood supply, arising from the same cusp of the aortic valve. In the most dangerous configuration, one of these coronary arteries passes between the aorta and the pulmonary artery. During strenuous exercise, as the heart rate and blood pressure increase, these two great vessels can expand and squeeze the anomalous artery shut, cutting off blood flow to the heart muscle at the moment of its greatest need. The result can be sudden cardiac death in a young, otherwise healthy individual. It is a tragic illustration of how a hidden, congenital flaw can create a fatal vulnerability, a perfect storm of anatomy and physiology. These cases of congenital anomalies underscore a crucial theme in our investigation: latent vulnerability. The body can function for years, even decades, with these hidden flaws. The system appears normal until a specific stressor, a rise in blood pressure, a moment of intense physical exertion, or simply the relentless passage of time leads to a sudden and catastrophic failure. They remind us that disease is not always an external attack or a process of internal decay. Sometimes, the enemy is a ghost in the original machine, a flaw in the blueprint present from day one. Our inquiry into the blueprints of betrayal is complete. In our next transmission, we will unlock the secrets of the scar within, exploring the vessel wall's desperate and often self-destructive response to injury. The scar within, a wall's desperate defense. We now continue our investigation into Part 3, the scar within. To understand the great vascular pathologies of hypertension and atherosclerosis, we must first understand the wall's own response to injury. For it is here, in the body's attempt to heal itself, that we find one of the most profound and tragic flaws in its design. The very process meant to repair damage often becomes the engine of the disease itself. To appreciate this paradox, we must meet the two key cellular players in this drama, the endothelial cell and the smooth muscle cell. First, the endothelial cell, or EC. This is the single-cell thick layer lining every blood vessel in the body. But to call it a simple lining is a gross understatement. The AC is the vigilant gatekeeper, the master regulator of vascular homeostasis. In its normal, basal state, its resume of responsibilities is staggering. It maintains a non-thrombogenic surface, actively producing factors like prostacyclin and nitric oxide that prevent clotting and keep blood in a fluid state. It modulates the tone of the underlying smooth muscle cells, thereby influencing blood pressure and flow. It regulates the passage of fluids, electrolytes, and cells into and out of the bloodstream. It metabolizes hormones, regulates inflammation, and controls the growth of other cell types. The SC is a versatile, multifunctional cell, and its proper function is absolutely critical for the health of the entire cardiovascular system. But this vigilant gatekeeper can be compromised. In response to a host of injurious stimuli, turbulent blood flow, high blood pressure, toxins from cigarette smoke, circulating lipid products, bacterial products, viruses, the SC undergoes a profound transformation. This process is called endothelial activation, or in its more pathological state, endothelial dysfunction. The gatekeeper turns. It shifts from an anti-inflammatory, anti-thrombotic state to a pro-inflammatory, pro-thrombogenic one. It begins to express adhesion molecules on its surface, beckoning inflammatory cells to stick to the vessel wall. It produces cytokines and chemokines that call for reinforcements. It starts making procoagulant factors that promote thrombosis. This activation is the alarm bell for vascular injury, the first sign that the wall is under attack. When that alarm sounds, the second key player enters the scene, the smooth muscle cell, or SMC. These are the predominant cells of the vascular media, the powerful repair crew of the vessel wall. While their best-known function is contraction and relaxation to control vessel tone, they have another, more ancient role. When appropriately stimulated, they can proliferate, and they can synthesize the extracellular matrix, the collagen, elastin, and protoglycans that form the vessel's structural scaffolding. And this brings us to the central plot point of this section, the body's one-size-fits-all patch kit for vascular damage, intimal thickening. When the endothelium is injured or becomes dysfunctional, a cascade begins. A distressed signal is sent out in the form of growth factors and cytokines released from platelets, activated endothelial cells, and macrophages. This signal calls the repair crew into action. Smooth muscle cells from the underlying media begin to migrate, crawling through the internal elastic lamina into the intima. They are joined by circulating smooth muscle precursor cells. Once in the intima, these SMCs undergo a transformation. They lose their contractile function and become synthetic powerhouses. They proliferate, and they begin to lay down new extracellular matrix, in much the same way a fibroblast fills in a wound in the skin. The result is the formation of a neointima, a new intimal layer composed of smooth muscle cells and matrix, which is eventually covered by a new layer of endothelial cells. This process of intimal thickening is the stereotypical response of the vessel wall to any insult. It doesn't matter if the injury is mechanical trauma, inflammation, or a metabolic derangement. The response is always the same. And herein lies the tragic flaw. This primitive, stereotyped healing mechanism, designed for acute, one-time injuries, becomes catastrophically maladaptive in the face of chronic, relentless injury. The scar that is meant to heal the wall becomes the disease itself. Excessive, uncontrolled intimal thickening leads to the progressive narrowing of the vessel lumen, a process called stenosis. The very act of repair ends up strangling the vessel it was meant to save. The scar within becomes the agent of obstruction. This is a concept of profound importance, a core theme that will recur throughout our investigation. This desperate, self-destructive healing response is a key player in the vascular lesions of hypertension. It is the fundamental process that builds the atherosclerotic plaque. And as we will see in our final case file, it is the very mechanism that sabotages our most advanced medical interventions, causing the failure of stents and bypass grafts. The body's defense becomes its own worst enemy. The wall's attempt to patch a breach ends up building a barricade. Our inquiry into the scar within is complete. In our next transmission, we will investigate the silent siege of hypertension, a relentless assault of pressure that pushes this flawed healing response to its deadly limits. The silent siege, pressure's relentless assault. We now continue our investigation into Part 4, the silent siege. We turn our attention now to an antagonist of unparalleled subtlety and reach. It is a silent, relentless force, an invisible pressure that batters the entire vascular system from the inside, day after day, year after year. It is hypertension, and its insidiousness lies in its silence. It typically remains asymptomatic until late in its course, a quiet siege that can go undetected for years while it inflicts devastating damage. Left untreated, roughly half of its victims will die of ischemic heart disease or congestive heart failure, and another third will die of stroke. It is a major risk factor for atherosclerosis, aortic dissection, and renal failure, and it is astonishingly common, affecting approximately 46% of adults in the general population. Our investigation into this silent killer begins with a search for its cause. In about 10% of cases, we can identify a clear culprit. This is secondary hypertension, and the suspects are often found in the kidneys or adrenal glands. A narrowing of the renal artery, a condition known as renal artery stenosis, can trigger it. So can adrenal diseases that produce excess hormones, like primary aldosteronism or Cushing's syndrome. In these cases, we have a clear lead, a specific pathology to target. But in approximately 90% of cases, the trail goes cold. This is essential hypertension, a diagnosis of exclusion. There is no single culprit, no smoking gun. Instead, we are faced with a complex, multifactorial conspiracy, a perfect storm of multiple genetic predispositions interacting with environmental factors like stress, obesity, smoking, physical inactivity, and, most notably, heavy salt consumption. It is a disorder with many authors. To understand how this conspiracy unfolds, we must first understand the body's exquisitely complex system for regulating blood pressure. Blood pressure is a function of two variables, cardiac output and peripheral vascular resistance. Cardiac output is determined by how much blood the heart pumps with each beat and how fast it beats. This is strongly influenced by blood volume, which is regulated by the kidneys through sodium homeostasis. Peripheral resistance is regulated predominantly at the level of the arterioles, those tiny gatekeepers whose diameter is controlled by a constant balance of neural and hormonal inputs. The key to this entire regulatory network, and the system that hypertension so effectively hijacks, is the renin-angiotensin-aldosterone system, or RAS. This is a powerful, ancient mechanism designed to preserve blood volume and pressure in times of need. It begins in the kidneys. Specialized cells near the glomeruli sense a drop in blood pressure and release an enzyme called renin. Renin acts on a plasma protein called angiotensinogen, cleaving it to form angiotensin I. As blood circulates through the lungs and other tissues, another enzyme, angiotensin-converting enzyme ACE, converts angiotensin I into the powerful molecule angiotensin-Roman II. Angiotensin-Roman II is the system's chief enforcer. It raises blood pressure through three distinct actions. First, it is a potent vasoconstrictor, causing smooth muscle cells in the arterioles to contract, thereby increasing peripheral resistance. Second, it travels to the adrenal gland and stimulates the secretion of the hormone, aldosterone. Aldosterone then acts on the distal tubules of the kidney, instructing them to reabsorb more sodium, and water follows the sodium. This increases total blood volume, which in turn increases cardiac output. Third, angiotensin-Roman II itself also directly increases sodium resorption in the kidney tubules. This is the chain of command, renin to angiotensin, I to angiotensin-Roman II, to aldosterone. It is a brilliant system for maintaining pressure, but in hypertension, this system runs amok, becoming a relentless driver of the disease. This brings us to one of the most critical insights into the nature of essential hypertension. It is a disease of resetting. Normally, if blood pressure rises, the kidneys respond by excreting more sodium and water, a process called pressure natriuresis, which brings the pressure back down. A key initiating event in essential hypertension may be a subtle defect in the kidney's ability to excrete sodium at a normal pressure. To get rid of the dietary salt load, the pressure has to rise. At this new, higher pressure, the kidneys can finally achieve sodium balance. The system has found a new equilibrium, but at a terrible cost. The body's own homeostatic mechanisms have been tricked into defending a dangerously high pressure as if it were the new normal. The regulators have become part of the problem, perpetuating a vicious cycle. Now, we must examine the crime scene, the microscopic evidence of hypertension's relentless assault on the small vessels. In the arterioles, we find two characteristic lesions. The first is hyaline arteriolosclerosis. Under the microscope, the arteriolar walls appear thickened, homogeneous, and pink, almost glassy. This change reflects the chronic hemodynamic stress. The high pressure physically forces plasma proteins to leak across the injured endothelium and deposit within the wall, while also stimulating the smooth muscle cells to produce excess matrix. The wall becomes thick and brittle, and the lumen narrows, further increasing downstream resistance and causing ischemic damage to the organs they supply. In cases of severe hypertension, we find a more dramatic and ominous lesion, hyperplastic arteriolosclerosis. Here, the vessels exhibit a concentric laminated thickening of their walls, which gives them a characteristic onion skin appearance. These laminations consist of proliferating smooth muscle cells and thickened, reduplicated basement membranes. It is the wall's desperate attempt to contain the extreme pressure, but in doing so, it often completely obliterates the lumen. In the most severe form, known as malignant hypertension, this is accompanied by fibrinoid necrosis, where the vessel wall itself begins to die and deposits of fibrin-containing proteins are seen. This is the microscopic signature of a system on the brink of collapse, a wall failing under a siege it can no longer withstand. Our inquiry into the silent siege of hypertension is complete. In our next transmission, we will open the case file on atherosclerosis, the grand conspiracy of plaque and time, and the single greatest cause of death in the Western world. The hardening, a conspiracy of plaque and time. We now continue our investigation into Part 5, the hardening. We now arrive at the central investigation of this chapter, the case that underlies more death and disability in the Western world than any other disorder. It is the cause of heart attacks, the majority of strokes, aortic aneurysms, and peripheral vascular disease. This is atherosclerosis, a name derived from the Greek words for gruel and hardening, a perfect description of the lesion it creates. But to call atherosclerosis a disease is to miss its true nature. It is not a single entity, but a slow-motion catastrophe, a chronic inflammatory and healing response of the arterial wall to a lifetime of injury. It is a grand conspiracy with multiple co-conspirators, a complex modus operandi, and devastating consequences. Let us first examine the rogues gallery of suspects, the risk factors that contribute to this conspiracy. They fall into two broad categories. First are the constitutional or non-modifiable factors. There is genetics. A family history of premature atherosclerosis is the most significant independent risk factor, a kind of familial curse. There is age. The development of plaque is a progressive process, and the incidence of myocardial infarction increases fivefold between the ages of 40 and 60. And there is male gender. Premenopausal women are relatively protected compared to age-matched men, a protection that is lost after menopause. More important for our purposes are the modifiable risk factors, the co-conspirators we can potentially bring to justice. The chief among these is hyperlipidemia, specifically high levels of low-density lipoprotein, or LDL, the infamous bad cholesterol. High LDL is sufficient to initiate lesions, even in the absence of other factors. Next is hypertension, the silent siege we have just investigated, which acts as a battering ram, accelerating the entire process. Then there is cigarette smoking, a toxic agent that poisons the endothelium and promotes thrombosis. And finally, there is diabetes mellitus, a metabolic accelerant that induces hypercholesterolemia and dramatically increases risk. Beyond these major players, there are emerging suspects. Chief among them is inflammation. We now know that inflammation is not just a consequence of atherosclerosis, it is a key driver at every stage. We can track its activity by measuring systemic markers like C-reactive protein, or CRP. High CRP levels are a strong, independent predictor of risk, and inside man signaling that the conspiracy is active. Other factors like hyperhomocysteinemia and the metabolic syndrome also play a role. Now, we must uncover the modus operandi, the step-by-step chronicle of how this conspiracy unfolds, a process best described by the response to injury hypothesis. It begins with Step 1, endothelial injury and dysfunction. The security system is breached. The delicate inner lining of the artery is damaged, not necessarily in a way we can see, but functionally. The culprits are the risk factors we've just met, the hemodynamic stress of turbulent blood flow, which is why plaques preferentially form at branch points and vessel origins, the toxins from smoke, and most importantly, the damaging effects of chronic hyperlipidemia. This leads to Step 2, accumulation of lipoproteins. LDL cholesterol begins to seep from the blood into the intima of the vessel wall. There, in the inflammatory environment, it becomes oxidized. This modification is critical. Oxidized LDL is no longer just a passive lipid, it is a toxic, pro-inflammatory weapon. Step 3, monocyte adhesion and transformation. The dysfunctional endothelium, now expressing adhesion molecules, acts like a strip of flypaper for circulating white blood cells, particularly monocytes. These monocytes stick to the wall, squeeze between the endothelial cells, and enter the intima. Once inside, they transform into macrophages. These macrophages are voracious. They begin to gorge on the accumulated oxidized LDL, but because they cannot fully break it down, they become engorged with lipid droplets. This transforms them into the hallmark cell of early atherosclerosis, the foam cell. The accumulation of these lipid-filled macrophages forms the earliest visible lesion, the fatty streak, the first footprints of the intruders. This process also triggers a critical inflammatory pathway known as the inflammasome, which releases the potent cytokine interleukin-1, creating a vicious, self-perpetuating cycle of inflammation that recruits even more inflammatory cells to the site. Finally, Step 4, smooth muscle proliferation and matrix production. The activated macrophages and T cells in the growing lesion release a cocktail of growth factors. This is the signal for the repair crew, the smooth muscle cells, to migrate from the media into the intima. Once there, they proliferate and begin to synthesize extracellular matrix, primarily collagen. It is this proliferation of smooth muscle cells and their deposition of dense collagen that builds the bulk of the mature lesion, converting a simple fatty streak into a complex, fibrofatty atheroma. Now we must examine the crime scene itself, the mature atherosclerotic plaque. It is a raised lesion that protrudes into the vessel lumen. On the surface is a firm, white fibrous cap composed of smooth muscle cells and dense collagen. Beneath this cap lies the dangerous, soft, gruel-like necrotic core. This core contains a chaotic mix of lipids, cholesterol and cholesterol esters, debris from dead cells, foam cells, and calcium. Under the microscope, the cholesterol often appears as empty, needle-shaped clefts, washed out during tissue processing. This brings us to the climax of our investigation, the devastating consequences of this conspiracy. The plaque can cause problems in two ways. The first is through slow, progressive growth, leading to atherosclerotic stenosis. As the plaque enlarges, it narrows the vessel lumen, compromising blood flow. When the occlusion reaches a critical stage, typically around 70% of the cross-sectional area, it can cause tissue ischemia, particularly during times of increased demand. In the coronary arteries, this manifests as stable angina, chest pain on exertion. But the far more dangerous outcome is acute plaque change. This is the sudden, catastrophic event that triggers a heart attack or stroke. And this is where we uncover the most crucial insight of our entire investigation. The clinical crisis of atherosclerosis is often an event of plaque biology, not plaque size. A large, heavily calcified plaque with a thick fibrous cap may cause chronic symptoms, but is relatively stable. The real killer is the vulnerable plaque. This is a plaque that may be small, causing no significant stenosis and no prior symptoms, but it has a treacherous architecture, a thin fibrous cap, a large lipid-rich necrotic core, and a dense inflammatory infiltrate. The inflammatory cells, particularly macrophages, secrete enzymes called metalloproteinases that degrade the collagen in the fibrous cap, weakening it from within. Then, a triggerous spike in blood pressure, intense physical or emotional stress can cause this fragile cap to rupture or fissure. The highly thrombogenic contents of the necrotic core are suddenly exposed to the bloodstream, triggering the immediate formation of a massive thrombus. This thrombus can completely occlude the vessel in minutes, leading to downstream infarction. This explains the terrifying reality of atherosclerosis. A catastrophic, fatal event can be the very first symptom of the disease, originating from a plaque that was, until that moment, small, silent, and invisible to standard diagnostic tests. The danger is not the visible mountain of a stable plaque, it is the unstable, smoldering volcano of a vulnerable one. Our inquiry into the hardening is complete. In our next transmission, we will investigate the breach, the terrifying scenarios that unfold when the vessel walls, weakened by these conspiracies, begin to fail. The breach when the walls begin to fail. We now continue our investigation into Part 6, the breach. Our focus now shifts from diseases of occlusion to diseases of structural collapse. We have seen how the vessel lumen can be slowly strangled or suddenly blocked. Now, we investigate the terrifying consequences that occur when the vessel wall itself, the very container of the river of life, begins to fail. This failure can manifest in two principal ways: as an aneurysm, a localized, abnormal dilation of the vessel, or as a dissection, a catastrophic event where blood tears its way into the substance of the vessel wall, carving a new and deadly channel. First, we must clarify our terminology. A true aneurysm involves an intact but attenuated wall, where all three layers intima, media, and adventitia are involved in the outpouching. These can be saccular, like a spherical bulge on one side of the vessel, or fusiform, a diffuse, circumferential dilation of a long segment. In contrast, a false aneurysm, or pseudoaneurysm, is not an aneurysm at all. It is a breach in the vessel wall that leads to an extravascular hematoma, a collection of blood outside the vessel that is contained only by the surrounding tissues. A dissection is a unique and particularly dangerous event where blood enters a defect in the arterial wall and tunnels between its layers, separating them. Dissections can cause the vessel to dilate, but their primary danger lies in their potential to rupture outwards or obstruct branch vessels. The central cause of all these structural failures is a compromised vessel wall. The integrity of the wall depends on the quality and quantity of its connective tissue, the health of its smooth muscle cells, and the balance between matrix synthesis and degradation. When this delicate balance is disturbed, the wall weakens. We can identify three main culprits behind this weakness. The first is intrinsically poor connective tissue quality. This is the realm of genetic defects. In the vascular form of Ehlers-Danlos syndrome, a mutation in the gene for type Roman III collagen results in fundamentally weak vessel walls. In Marfan syndrome, a defect in the scaffolding protein fibrillin leads to abnormal signaling by a molecule called transforming growth factor beta TGF-beta, which disrupts the proper formation of the extracellular matrix, particularly in the ascending aorta. The second culprit is excessive extracellular matrix degradation. This is often driven by inflammation. In the setting of a severe atherosclerotic plaque, for example, the wall is infiltrated by inflammatory cells, particularly macrophages. These activated macrophages produce enzymes called matrix metalloproteinases, or MBBS, which are capable of chewing through the structural proteins of the wall, the collagen and elastin. This enzymatic degradation weakens the wall from within, predisposing it to dilation. The third culprit is the loss of smooth muscle cells due to ischemia. The vascular media is a living tissue that requires a constant supply of oxygen and nutrients. This supply can be compromised in two ways. A large atherosclerotic plaque can act as a barrier, increasing the diffusion distance from the lumen and starving the inner media. Alternatively, systemic hypertension can cause damage and narrowing of the vasa vasorum, the small vessels that supply the outer media. Both pathways lead to ischemia, smooth muscle cell death, and their replacement by a disorganized, a cellular matrix. This process, known as cystic medial degeneration, leaves the wall weak and vulnerable to the relentless pounding of arterial pressure. These mechanisms lead us to a profound understanding of how the two great vascular conspiracies, atherosclerosis and hypertension, work as a destructive duo to attack the aorta, the body's largest and most critical vessel. Atherosclerosis, with its inflammatory infiltrates and its barrier to diffusion, weakens the wall from the inside out. For reasons related to hemodynamics, this process is most severe in the abdominal aorta. This is why atherosclerosis is the prime suspect in the formation of an abdominal aortic aneurysm, or AAA. These aneurysms typically occur below the origin of the renal arteries. The wall becomes thin, the median is destroyed, and the lumen is often filled with a poorly organized mural thrombus. Most are asymptomatic, discovered incidentally as a pulsating abdominal mass. But their danger is immense. The risk of rupture is directly related to their size. For an aneurysm over 6 cm in diameter, the annual risk of rupture is a terrifying 25%. A rupture into the peritoneal cavity is a massive, usually fatal hemorrhage. Hypertension, on the other hand, attacks the aorta through sheer mechanical stress and by starving it from the outside in by damaging the vasa vasorum. Its effects are most pronounced in the thoracic aorta. Hypertension is the major risk factor for aortic dissection. The event is typically initiated by a small tear in the intima of the ascending aorta. Blood, under immense systolic pressure, surges through this tear and begins to carve a channel within the media, separating its laminar planes. The classic symptom is the sudden onset of excruciating, tearing chest pain, often radiating to the back between the scapulae. The dissection can propagate down the length of the aorta, and its consequences are catastrophic. It can rupture through the adventitia into the pericardial sac, causing cardiac tamponade. It can dissect backwards into the aortic root, disrupting the aortic valve, or it can shear off the origins of the great vessels branching from the aorta, causing a stroke, a myocardial infarction, or kidney failure. Aortic dissections are classified based on their location. Type A dissections, which involve the ascending aorta, are the most common and the most dangerous, requiring immediate surgical intervention. Type B dissections, which are confined to the descending aorta, can often be managed medically. But, in either case, a dissection represents one of the most acute and life-threatening emergencies in all of medicine, a true breach in the body's most vital pipeline. Our inquiry into the breach is complete. In our next transmission, we will turn to a strange and complex conflict, vasculitis, the cases of friendly fire where the body's own immune system wages a civil war against its vascular infrastructure. Friendly fire, the immune system's civil war. We now continue our investigation into Part 7, Friendly Fire. We enter now a battlefield of bewildering complexity, a theater of operations where the lines between friend and foe have been erased. This is vasculitis, a general term for inflammation of the vessel wall. But this is no ordinary inflammation in response to an external invader. This is a civil war, a case of friendly fire where the body's own immune system turns its powerful weapons against its own vascular infrastructure. The clinical manifestations of this war are protean, depending entirely on which vascular bed is under attack. But the conflict is almost always systemic, accompanied by constitutional signs and symptoms: fever, myalgias, arthralgias, and malaise, the telltale signs of a body at war with itself. There are some 20 recognized forms of this disease, and our investigation must begin by understanding the primary mechanisms of attack, the immunologic weapons used in this internal conflict. The first mechanism is immune complex deposition. This is a form of collateral damage. In certain conditions, antibodies bind to antigens which could be components of a drug, a microbe like the hepatitis B virus, or even one of an individual's own proteins to form immune complexes. These complexes circulate in the bloodstream and can become deposited in the walls of small vessels. Their presence triggers an intense inflammatory reaction, activating complement and recruiting neutrophils that release their destructive enzymes, damaging the vessel wall. The second and perhaps more insidious mechanism involves antineutrophil cytoplasmic antibodies or ANCAs. This is a case of mistaken identity on a devastating scale. For reasons we do not fully understand, the immune system creates autoantibodies against proteins that are normally sequestered inside its own neutrophils. There are two main targets. The first is proteinase-3, giving rise to PR3 ANCA. The second is myeloperoxidase, giving rise to MPO ANCA. The presence of these antibodies alone is not enough to cause disease. But during an infection or other inflammatory stimulus, neutrophils become activated, and they begin to express small amounts of these target proteins on their cell surface. The circulating ANCA now have a target. They bind to the neutrophils, triggering them to degranulate and release a storm of reactive oxygen species and proteolytic enzymes. The result is a direct, ferocious attack on the vessel wall, particularly the delicate endothelium. Because this attack is direct and not caused by the deposition of immune complexes, these forms of vasculitis are often described as pauci-immune. The third mechanism is the formation of anti-endothelial cell antibodies, a direct assault on the gatekeepers themselves, which we believe plays a role in certain vasculitides like Kawasaki disease. Understanding these mechanisms is crucial, but the key to navigating this complex battlefield is to recognize that the classification of vasculitis by vessel size is not merely an academic exercise, it is the single most powerful tool for predicting the clinical consequences. The caliber of the vessel under attack directly determines the organ system that will be damaged and the symptoms that will manifest. Let us begin with the large vessel vasculitides, campaigns against the body's main highways. Here we find giant cell arteritis, also known as temporal arteritis. This is a granulomatous inflammation that targets the arteries of the head, typically in individuals over the age of 50. It can cause vague symptoms like fever and fatigue, or a severe, localized headache. But its greatest danger lies in its potential to involve the ophthalmic artery. The resulting occlusion can cause sudden, irreversible blindness, making it a true medical emergency. A related entity is Takayasu arteritis, which also causes granulomatous inflammation of large arteries but typically affects individuals younger than 50. It has a predilection for the aortic arch and the great vessels that branch from it. The inflammation causes such severe thickening and narrowing of these vessels that it can lead to a marked weakening of the pulses in the upper extremities, earning it the name pulseless disease. It is a shutdown of the primary circulation to the arms and head. Next, we investigate the medium vessel vasculitides, which cause organ-specific infarcts. The classic example is polyarteritis nodosa, or PAN. This is a systemic, necrotizing vasculitis that typically affects the renal and visceral arteries, but in a key diagnostic clue spares the pulmonary circulation. In about a third of cases, it is associated with chronic hepatitis B infection, a clear case of immune complex-mediated disease. The other major entity in this category is Kawasaki disease, a mysterious and acute illness of infancy and childhood. It presents with fever, rash, and lymph node enlargement, but its clinical significance stems from its terrifying predilection for the coronary arteries. The inflammation can lead to the formation of aneurysms that can rupture or thrombose, causing myocardial infarction in a young child. It is a high-stakes battle for the heart's own vital supply lines. Finally, we descend to the smallest vessels, the capillaries, arterioles, and venules. The small vessel vasculitides cause diseases of widespread leakage and microinfarction. Microscopic polyangiitis is a necrotizing vasculitis of these small vessels, often associated with MPO ANCA. It frequently involves the lungs, causing pulmonary capillaritis and hemorrhage, and the kidneys, causing a rapidly progressive glomerulonephritis. A more complex and devastating entity is granulomatosis with polyangiitis, or GPA. This disease is characterized by a terrifying triad: necrotizing granulomas in the upper or lower respiratory tract, a necrotizing vasculitis of small to medium vessels, and a necrotizing glomerulonephritis. It is strongly associated with PR3 ANCA and represents a multi-front assault on the respiratory system and the kidneys. One final, unique case file in this category is thromboangiitis obliterans or Buerger disease. This is a segmental, thrombosing vasculitis of the medium and small arteries of the extremities. It has an absolute and unequivocal link to one environmental factor, heavy cigarette smoking. It occurs almost exclusively in smokers, usually before the age of 35, and causes severe pain and vascular insufficiency that can lead to gangrene of the fingers and toes. It is a stark example of a direct, toxic, and inflammatory assault on the distal vasculature. This tour of the battlefield reveals the logic behind the chaos. By identifying the size of the vessel under attack, large, medium, or small, and by searching for the immunologic signature immune complexes or specific ANCAs, we can begin to make sense of this internal civil war and predict where the next attack will fall. Our inquiry into friendly fire is complete. In our next transmission, we will investigate a phantom menace, a threat that is not structural but functional, the ghostly hand of vasospasm. The phantom menace, spasms of a ghostly hand. We now continue our investigation into Part 8, the phantom menace. Until now, our investigation has focused on tangible culprits, the buildup of plaque, the formation of a thrombus, the inflammation of a vessel wall, the rupture of an aneurysm. We have been investigating crimes with clear physical evidence. But now we turn to a more elusive adversary, a threat that is functional, not structural. This is the phantom menace of vasospasm, a condition where the vessel itself may be perfectly intact, but it clamps shut inappropriately, guided by a ghostly, invisible hand. This category of disease reveals a crucial truth: the complex control system that governs vascular tone can itself be a source of pathology. It demonstrates that disease isn't always about a physical lesion. It can be a purely physiological derangement, a software failure in addition to a hardware failure. The consequences of this failure, however, can be just as severe as a physical obstruction. The classic case file for this phenomenon is Raynaud phenomenon. This condition results from an exaggerated vasoconstriction of arteries and arterioles, typically in the extremities, in response to cold or emotional stress. The restricted blood flow induces a dramatic and characteristic sequence of color changes. The affected digits, fingers, and toes are most common. First turn a stark, deathly white as the arteries clamp down and blood flow ceases. This is followed by a cyanotic, blue discoloration, as the trapped blood desaturates of oxygen. Finally, as the spasm resolves and blood flow returns, there is a reactive hyperemia, and the digits turn a bright, painful red. This classic red, white, and blue sequence is the hallmark of a vascular system in a state of hyperreactivity. It is critical to distinguish between the two forms of this condition. Primary Raynaud phenomenon is an idiopathic condition, most common in young women. It appears to be an intrinsic hyperreactivity of the smooth muscle cells themselves. The course is usually benign, and while it can be uncomfortable, it rarely leads to severe tissue damage. The vascular structure is normal. Secondary Raynaud phenomenon, however, is a more ominous sign. Here, the vasospasm is a symptom of an underlying disease. It can be the first manifestation of a serious autoimmune condition like systemic lupus erythematosus or scleroderma. It can be associated with atherosclerosis or Buerger disease. In these cases, the Raynaud phenomenon is not the disease itself, but a crucial clue, a warning sign that a larger, more systemic investigation is needed. Any patient presenting with new-onset Raynaud phenomenon must be carefully evaluated for an underlying disorder, as it may be the harbinger of a more significant pathology. While Raynaud phenomenon in the extremities is the most common example, this pathological vasospasm can occur elsewhere, with far more deadly consequences. Excessive constriction of the coronary arteries, sometimes called cardiac Raynaud, can cause myocardial ischemia. This can be triggered by high levels of vasoactive substances, such as epinephrine from an adrenal tumor, or exogenous drugs like cocaine. If the vasospasm is severe and prolonged, lasting 20 to 30 minutes, it can cause a true myocardial infarction, even in the absence of any significant atherosclerotic plaque. It is a heart attack caused not by a blockage, but by a ghost in the machine, a purely functional derangement of the vessel's control system. This phantom menace forces us to broaden our understanding of vascular pathology. It is a reminder that the health of the crimson rivers depends not only on the integrity of their walls, but also on the precision and stability of the invisible network of signals that controls them. A failure in this programming can be as deadly as any physical flaw. Our inquiry into the phantom menace is complete. In our next transmission, we will explore the forgotten pathways of the venous and lymphatic systems, where the primary threats are not high-pressure blowouts, but the quiet dangers of stagnation and sabotage. The forgotten pathways, stagnation, and sabotage. We now continue our investigation into Part 9, the forgotten pathways. We now turn our investigation away from the high-pressure, high-velocity world of the arteries to the often overlooked, low-pressure drainage and return channels of the metropolis, the venous and lymphatic systems. The diseases here are of a different nature. They are not stories of high-pressure blowouts and explosive ruptures, but of stagnation, congestion, and insidious backflow. The primary threat in these forgotten pathways is the system's own sluggishness. Let us first examine the veins. The most common pathology here is the development of varicose veins. These are abnormally dilated, tortuous veins that arise from prolonged increased intraluminal pressure. This pressure stretches the vein wall and renders its delicate one-way valves incompetent. With the valves failing, the column of blood exerts even more pressure on the walls below, creating a vicious cycle of dilation and valvular failure. It is a story of failing floodgates. This is most common in the superficial veins of the legs, where prolonged standing can dramatically increase venous pressure. Obesity and pregnancy are major risk factors. While these superficial varicosities can lead to stasis, congestion, edema, and painful skin ulcers, they rarely give rise to emboli. However, varicosities in other locations can be far more dangerous. In patients with liver cirrhosis, the resulting portal vein hypertension forces blood to be rerouted through collateral channels. This leads to the formation of esophageal varices, massively dilated veins at the gastroesophageal junction. These are thin-walled and lie just beneath the mucosa, and their rupture can lead to massive, often fatal, upper gastrointestinal hemorrhage. A similar process at the anorrectal junction gives rise to hemorrhoids, which, while less dangerous, can be a source of significant discomfort and bleeding. The most lethal threat originating in the venous system, however, is thrombophlebitis, or venous thrombosis. Over 90% of cases occur in the deep veins of the leg, a condition known as deep venous thrombosis, or DVT. And this is where we see the venous system's greatest vulnerability. Unlike the high-velocity arterial system, the low-flow, low-pressure venous environment is predisposed to stasis of blood. This stasis is one of the three key components of Virchow's triad for thrombosis. This makes DVT a crime of opportunity, enabled by the very nature of the system. The most common cause is prolonged immobilization, extended bed rest after surgery, long airplane flights, or long car rides where the muscular pump of the legs is not active to help propel blood forward. Other risk factors include congestive heart failure, pregnancy, oral contraceptive use, and the hypercoagulable states associated with cancer. The great danger of a DVT is not local, but distant. The thrombus in the deep leg vein is often asymptomatic, a silent killer in waiting. The catastrophic event occurs when a piece of this thrombus breaks off, travels through the venous circulation, through the right side of the heart, and becomes lodged in the pulmonary arteries. This is a pulmonary embolism, one of the most feared complications in medicine. A large embolus can cause sudden death. In many cases, a massive pulmonary embolus is the very first manifestation of an underlying DVT. Next, we turn to the parallel drainage system, the lymphatics. Here, an acute bacterial infection, most commonly by Streptococcus, can lead to lymphangitis. The inflamed lymphatics appear as painful, red subcutaneous streaks, often accompanied by tender enlargement of the draining lymph nodes. It is a sign that the body's drainage system has been breached by an invader. A more chronic and debilitating condition is lymphedema, the accumulation of interstitial fluid due to a blockage of lymphatic drainage. This can be a primary congenital defect, but more often it is secondary to another process. Tumors can obstruct lymphatic channels. Surgical procedures, such as the removal of axillary lymph nodes during a mastectomy for breast cancer, can sever lymphatic connections. Post-radiation fibrosis can scar them shut. And in certain tropical regions, a parasitic infection called filariasis can cause a massive, obstructive lymphedema known as elephantiasis. Regardless of the cause, the blockage leads to a chronic, protein-rich edema. Over time, this stimulates fibrosis in the skin and subcutaneous tissues, leading to a characteristic brawny induration and a thickened, pitted appearance of the skin known as peau d'orange or orange peel skin. The tissue becomes vulnerable to ulceration and poor healing. The pathologies of these forgotten pathways serve as a crucial reminder. The health of the vascular metropolis depends not only on the integrity of its high-pressure supply lines, but also on the unimpeded function of its low-pressure drainage systems. When these systems fail, the result is not an explosion, but a flood, a quiet, insidious process of stagnation and sabotage that can be just as deadly. Our inquiry into the forgotten pathways is complete. In our next transmission, we will investigate the rogue builders, the uncontrolled and cancerous growths that can arise within the pipelines themselves. The rogue builders, uncontrolled growth in the pipelines. We now continue our investigation into Part 10, the rogue builders. Our investigation now shifts to a fundamentally different kind of threat, neoplasia. Here, the danger comes not from a failure of the existing infrastructure, but from the emergence of rogue cells that begin to build unauthorized and dangerous new structures within the vascular network. These vascular tumors constitute a wide spectrum, from the extremely common and benign to the rare and highly malignant. Our first task as investigators is to distinguish between them. Benign tumors typically form obvious vascular channels lined by a single layer of normal-appearing endothelial cells. Malignant tumors, in contrast, are more solidly cellular, exhibit cytologic atypia, and often fail to form well-organized vessels. Let us begin with the benign tumors. The most common are the hemangiomas, tumors composed of blood-filled vessels. They are extremely common in infancy and childhood. Capillary hemangiomas are the most frequent type, composed of thin-walled capillaries. The juvenile or strawberry hemangioma of the newborn is a classic example, which often grows rapidly for a few months before spontaneously regressing. Cavernous hemangiomas are composed of larger, more dilated vascular channels. They are more infiltrative and do not regress. While often of only cosmetic significance, a cavernous hemangioma in the brain can be a serious problem, capable of causing seizures or hemorrhage. Another common variant is the pyogenic granuloma, a rapidly growing red nodule on the skin or oral mucosa that bleeds easily. Despite its name, it is neither infectious nor granulomatous. It is a form of capillary hemangioma. The lymphatic counterparts to these tumors are the lymphangiomas. A key diagnostic clue allows us to distinguish them. Tumors of blood vessels are filled with blood. Tumors of lymphatics are filled with clear lymph. The cavernous lymphangioma, also known as a cystic hygroma, is typically found in the neck or axilla of children and can grow to an enormous size. It is a common finding in Turner syndrome. Finally, in the benign category, we have the glomus tumor. This is a small but exquisitely painful tumor arising from the modified smooth muscle cells of glomus bodies, which are structures involved in thermoregulation. They are most commonly found under the fingernails. Moving up the spectrum of aggression, we encounter the intermediate-grade tumors. The most important and complex entity in this category is Kaposi sarcoma, or KS. This is not a conventional cancer, but a hostile takeover orchestrated by a virus, human herpesvirus 8HH-VAIT, which thrives in the setting of a compromised immune system. There are 4 distinct clinical forms. Classic KS affects older men of Mediterranean descent. Endemic African KS is common in Central Africa, even in HIV-negative individuals. Transplant-associated KS occurs in organ transplant recipients on immunosuppressive therapy. And most famously, AIDS-associated KS is an AIDS-defining illness and the most common HIV-related malignancy worldwide. The pathogenesis of KS is a fascinating story of viral hijacking. HHV infects endothelial cells. A virally encoded protein then mimics a cellular signaling molecule, inducing the production of vascular endothelial growth factor, or VEGF, which drives the proliferation of the endothelial cells. Other viral proteins disable the cell's normal growth controls and prevent apoptosis. The virus essentially forces the host cells to build a tumor that serves as a new home for the virus. The lesions progress from flat, red-purple patches to raised plaques, and finally to nodules composed of proliferating spindle cells forming slit-like vascular spaces. This case highlights a profound biological mystery: the blurry line between a reactive proliferation and a true neoplasm. We see a similar phenomenon in bacillary angiomatosis, a vascular proliferation seen in immunocompromised hosts caused by bacteria of the Bartonella family. Here, the bacteria induce the host tissue to produce growth factors that drive vascular proliferation, creating lesions that can mimic Kaposi sarcoma. But this is an infection, not a true tumor, and it resolves with antibiotics. These cases show how an external agent can hijack the vessel's own growth programs to create a structure that looks and acts like a cancer. Finally, we arrive at the truly malignant tumors. The most important of these is the angiosarcoma, a highly malignant cancer of endothelial cells. These are aggressive tumors that can arise anywhere but are most common in the skin, soft tissue, breast, and liver. They can be induced by a variety of factors. They can arise in the setting of chronic lymphedema, a condition known as Stewart-Treves syndrome, classically seen in the arm of a woman many years after a radical mastectomy. They can be induced by radiation. And hepatic angiosarcomas have been linked to specific carcinogens, including arsenic, thorotrast, a radioactive contrast agent, and polyvinyl chloride. Angiosarcomas are locally invasive and metastasize readily, carrying a grim prognosis. Our inquiry into the rogue builders is complete. In our final transmission, we will examine the ultimate irony of vascular pathology, the fix and the flaw, the cases where our own attempts to cure the disease create a new and formidable crisis. The fix and the flaw, when the cure creates a crisis. We now continue our investigation into Part 11, the fix and the flaw. We have reached the end of our investigation, and we are confronted with a final, profound irony. Our last case file examines the consequences of our own interventions. We have developed powerful tools to fight vascular disease, stents to open blocked arteries, grafts to bypass them, but in doing so, we have come face to face with the body's own fundamental and often tragically maladaptive biological responses. We have discovered that the cure can plant the seeds of a new crisis, and that our greatest adversary is often the very healing process we are trying to assist. Consider the case of endovascular stenting. When a coronary artery is critically narrowed by an atherosclerotic plaque, we can perform an angioplasty, inflating a balloon to crack the plaque and restore flow. To prevent the vessel from collapsing, we then deploy a stent, a metallic mesh scaffold, to hold the artery open. This is a brilliant mechanical solution, but it comes at a biological cost. The act of angioplasty and stenting causes significant injury to the vessel wall. It denudes the endothelium and damages the media. And how does the vessel wall respond to this injury? It responds in the only way it knows how. It activates the stereotyped response to injury that we first encountered at the very beginning of our investigation. Smooth muscle cells migrate from the media into the intima. They proliferate, and they lay down new extracellular matrix. This new tissue, this neointima, begins to grow over and through the struts of the metallic stent. The scar that is meant to heal the injury ends up re-occluding the vessel. This process is called in-stent restenosis. The very healing response we have been investigating all along returns as the primary mechanism of failure for our intervention. The scar within grows through the stent mesh, and strangles the lumen once again. To combat this, the next generation of technology was developed, drug-eluting stents. These stents are coated with a polymer that slowly leaches an antiproliferative drug, like paclitaxel or sirolimus, into the adjacent vessel wall. These drugs block the activation and proliferation of the smooth muscle cells, dramatically reducing the rates of in-stent restenosis. But this solution creates a new, and in some ways more dangerous, problem. By inhibiting the healing response, these drugs also significantly delay the process of re-endothelialization. The metallic struts of the stent remain exposed to the bloodstream for a much longer period. This leaves the stent highly thrombogenic, a potent trigger for clot formation. Patients with drug-eluting stents must therefore remain on powerful antiplatelet therapies for an extended period, sometimes a year or more, to prevent a catastrophic acute stent thrombosis. It is a delicate and dangerous trade-off. We can suppress the scar, but at the cost of delayed healing and an increased risk of clotting. A similar story unfolds in vascular replacement or bypass surgery. When a coronary artery is completely blocked, we can bypass the obstruction using a graft. The best grafts are arteries like the internal mammary artery. But often, we must use a segment of the patient's own saphenous vein taken from the leg. Here, we are taking a vessel that was designed for the low-pressure, low-flow environment of the venous system and suturing it into the high-pressure, pulsatile battlefield of the arterial circulation. The vein graft responds to this unaccustomed mechanical stress with an aggressive and progressive intimal hyperplasia. Over months and years, the wall thickens, and eventually, the vein graft itself, now existing in a high-pressure, high-lipid environment, begins to develop its own accelerated and aggressive form of atherosclerosis. The long-term patency of saphenous vein grafts is poor, with only about 50% remaining open at 10 years. The failure is driven by the same fundamental process, the vessel's primitive, stereotyped response to an injurious new environment. And so our investigation comes full circle. The very first pathological mechanism we identified, the formation of a neointima, the scar within, returns as the final antagonist, sabotaging our most sophisticated efforts to repair the system. It demonstrates that a deep understanding of this one fundamental principle of vascular pathology is the key to understanding everything from the natural history of atherosclerosis to the complications of modern surgery. The diseases of the Crimson Rivers are not a collection of unrelated phenomena. They are chapters in a single, epic story, a thriller of injury and response of a brilliant but flawed system battling against a relentless series of threats, both from without and from within. The story is written in the language of cells and molecules, but its themes are universal: the struggle for survival, the paradox of a defense that becomes a weapon, and the unending, intricate dance between life and death.